Question number 7. A 36-year-old female was admitted with a diagnosis of congestive heart failure. On the second day of admission, she started to have high-grade fever and nocturnal cough. On physical examination, respiratory rate is 40 breaths per minute, and axillary temperature is 39 degrees Celsius. Chest X-ray showed homogeneous opacity in the lung obscuring the aortic knob. Which lobe is affected? A. Right upper lobe. B. Left upper lobe. C. Lingular. D. Left lower lobe. The aortic knob or knuckle refers to the frontal chest X-ray appearance of the distal aortic arch as it curves posterolaterally to continue as the descending thoracic aorta. It appears as a laterally projecting bulge, as the medial aspect of the aorta cannot be seen separate from the mediastinum. It forms the superior border of the left cardiomediastinal contour. When a chest X-ray shows homogeneous opacity, obscuring the aortic knob with the presence of fever and respiratory distress, it suggests that there is an increased density in the lung tissue adjacent to the aortic knob, which is the left upper lobe of the lung. This increased density could be due to fluid, pus or cells filling the airspace or thickening of the walls of the alveoli, or the space between the lungs. In the context of the patient's symptoms, high-grade fever, nocturnal cough, and a rapid respiratory rate, it is likely indicative of an infection or inflammation in the left upper lobe, consistent with lobar pneumonia. Pneumonia is a common complication in patients with congestive heart failure due to fluid overload and decreased lung compliance. The other options, such as the right upper lobe, lingular, and left lower lobe, are less likely to be involved if the opacity is obscuring the aortic knob, as these areas are anatomically separate from the location of the aortic knob. Let's continue case number 8. A 45-year-old man came with hoarseness of voice of 2 months duration. The CT scan revealed left vocal cord paralysis secondary to a compressive tumor in the course of the cranial nerve 10. Cranial nerve 9 and cranial nerve 12 are spared. Where is the tumor located? A. Left jugular foramen. B. Foramen magnum. C. Left carotid space. D. Aortopulmonary window. The correct answer is choice C, the left carotid space. The vagus nerve is responsible for the motor innervation of the laryngeal muscles, including those controlling the vocal cords. When considering the anatomical course of the vagus nerve, the most likely location of the tumor from the given options would be the left carotid space. This space is an anatomic compartment where the carotid artery, internal jugular vein, and cranial nerve 10 or the vagus nerve are located embedded within the carotid sheath, highlighted with red arrow and red circles in the figure. A tumor in this area could compress the vagus nerve, leading to vocal cord paralysis. Vocal cord paralysis can indeed be caused by lesions along the vagus nerve or its recurrent laryngeal branch, and imaging can help in localizing the pathology. The left jugular foramen is where the glossopharyngeal vagus and accessory nerves exit the skull. However, since the other cranial nerves are spared, this location is less likely. The foramen magnum is the opening at the base of the skull through which the spinal cord passes, and it is not typically associated with isolated cranial nerve 10 compression. Lastly, the aortopulmonary window is an area in the mediastinum not directly related to the course of the vagus nerve. Let's discuss the clinical anatomy of the vagus nerve and the carotid spaces. The final 4 cranial nerves nerves 9 through 12, all leave the skull together through the jugular foramen. The vagus nerve, represented in the image by the pink color, exits the skull through the jugular foramen. Within the neck, it travels within the carotid space isolated from the three cranial nerves, namely cranial nerve 9, cranial nerve 11, and cranial nerve 12. Therefore, the carotid space contains the neurovascular compartment of the neck, specifically the common carotid artery, internal jugular vein, and the vagus nerve among the four cranial nerves. As mentioned above, the branches of the vagus nerve provides both sensory and motor supply to the laryngeal muscles and the vocal cords. The recurrent laryngeal nerve innervates most intrinsic muscles of the larynx, including those responsible for controlling the vocal cords, whereas the external laryngeal nerve innervates the cricothyroid muscle. Once a mass is localized to the carotid space, also known as the post-styloid parapharyngeal space in the suprahyoid neck, the differential becomes narrow and relates to structures that occur within it. It contains mainly neural and vascular structures, including the structures within the carotid sheath, the carotid artery, the internal jugular vein, and the lower four cranial nerves. The sympathetic chain and phrenic nerve do not lie within the carotid sheath, but are considered within this carotid space. Lymph nodes also lie in this region. The pathologies include paragangliomas and nerve sheath tumors arising from lower cranial nerves or from the sympathetic chain. Nodal metastasis, abscess, and venous thrombosis are also differential considerations, as well as an extracranial carotid artery aneurysm. Lesions such as schwannomas or paragangliomas, which arise in the carotid sheath, will be intimately related to the vessels and may involve or separate them in characteristic patterns, whereas lymph nodes generally displace the carotid and jugular vessels together. Paragangliomas are generally hypervascular and may have shunting with early draining veins. This table summarizes benign and malignant tumors arising in the carotid space.